Coming up today, half of all Americans will develop nodules on their thyroid. Now there's a way to treat the nodules without an incision. Today, meet a woman who was ready to fly across the country before finding a specialist close to home. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Going under the knife isn't always the best option, and if you had the choice between surgery and a less invasive procedure, why not skip the scalpel? Today, we are learning about a new procedure to treat thyroid nodules. They are surprisingly common and are usually non-cancerous. If the nodules are small, you may not even notice them. But if they grow, they can be painful and even make it hard to swallow. Until recently, the only treatment was to remove the thyroid altogether. But now a technique already used on other parts of the body can be used on the thyroid. Today, we are talking with a woman who searched for it and she found it. And it's a treatment known as radiofrequency ablation, or RFA. Sandy Fallon is joining us virtually from her home in Topeka. Sandy, good morning.
Good morning, Jessica.
Good to have you. Thanks for being here to share your story. There are only about 75 doctors in the country that do this procedure, and I'm sitting next to two of them right here at the desk, Dr. Alan Reeves across from me and Dr. John Matarang. They are both interventional neuroradiologists here at the health system, and a lot of their work happens inside the vessels of the brain, but today we are talking about the thyroid. So, guys, good to have you here with us. We're going to talk to you in just a moment, but I want to get back to Sandy because she's going to take us back to October of 2021. You had a routine doctor's visit, right? What did they notice about your thyroid?
It's big. She was palpating my neck, and she said, "Oh, your thyroid's kind of big," which after that, I looked at myself in the mirror and went, "Well, I was completely overlooking the obvious," because yes, there was a noticeable lump on my left side. And so she, of course, sent me on to recommend biopsy, ultrasound, etc., which I did follow through all that. And by December then, I knew for sure it was not cancerous. I'd had a biopsy done here in Topeka. So I wasn't really worried about that, but I was not thrilled with the way it appeared. And I was concerned about the future as to whether it would continue to grow.
So had you noticed it before the doctor had and you just didn't know what it was? What were you thinking?
You know, honestly, I was completely oblivious, which sounds ridiculous because then afterwards I'm looking at myself and going, how did I overlook that lump right there? I mean, it wasn't massive, but it was noticeable. And I think you have a photo that you can see what it looked like by the time I was getting ready to have the procedure.
Yeah,
there you go. A bit of a lump. I wasn't to the point where I was scaring small children when I'd go out in public, but, it was not exactly normal nor attractive. And by the time a year later, it had grown more, and it was starting to annoy me. Certain necklines of my clothing, I would notice it.
Well, that's a good way of putting it. You're not oblivious to it, but sometimes if it's not if it's not too noticeable, it's not really bothering you, you might overlook something and not necessarily go to the doctor right away. What treatment options were you given when you finally did go to the doctor?
Well, I was referred from my primary care physician to ear, nose, and throat specialist, obviously, and I went to one here in Topeka, who I don't think I'd been in the office 5-10 minutes when one of the first things that I heard was, well, we can always take it out. And by that point, I had already done let's face it, research is readily available to us these days. And I had already done my own homework, and I was aware of the RFA procedure being used for thyroid nodules. But it's not being done here in Topeka. And the specialist, ear, nose, and throat specialist who I visited with had maybe passing knowledge that it was out there, but at that point I probably knew more about what was going on than he did. And so I decided at that point I would just live with the enlargement for a while and reassess in maybe another 6 months to a year.
Was there a concern on the doctor's end or even your end that this might be cancerous?
No, because after my consultation with the ENT physician, I then went on to the biopsy within a week or two when I could get it scheduled, and 6 samples of various nodules, because I had more than one, but the other ones were quite a bit smaller. at any rate, the samplings were all negative for cancer. I had no symptoms. My thyroid was performing just as it's supposed to. So I was perfectly healthy. I just had a lump in my thyroid.
Well, and you said your thyroid was doing what it's supposed to be doing. So I want to bring in Dr. Reeves because I want to have him take us kind of back to the basics. What is the purpose and the function of the thyroid?
Sure, that's a really good question, and it's particularly germane when you're talking about surgery and removing part of the thyroid. So the thyroid serves as sort of a central command center for a lot of the body's metabolic functions, either speeding up or slowing down. And I think it's best to understand what the thyroid does when it's not there. So when it's not there, the body can experience gut motility issues, temperature regulation issues. You may be cold, heart rate may slow down, you may feel lethargic and drowsy. So it's one of those special glands in the body that's situated right in the very front of your neck, below your Adam's apple, that has a lot of understated roles. But people really start to notice it when the thyroid is not there. And so that really comes into play for us when we're discussing treatment options for patients with thyroid nodules. So if you take out a nodule, generally you have to remove most or all of the thyroid gland, and then that can lead to permanent hormone replacement and issues for the rest of your life trying to deal with getting those hormones back to the levels they need to be.
So what is the thyroid trying to regulate?
Well, it does a lot of metabolic functions. And so every part of your body is involved with metabolic functions, your brain, your gut, your heart. So those things are regulated by thyroid hormones in part. And so, like I said, I think that most of the time people notice the issues when those hormones are not present. And so when the thyroid gland can't secrete the hormones that it needs to help regulate the metabolic functions, you're going to feel it in some form or fashion.
So what is causing those nodules to appear?
That's a great question. They tend to develop more with age. They're incredibly common. So I think between John and I, it feels like we do about 100 biopsies a day for a thyroid nodule. And by and large, these are almost always benign. Greater than 90% are benign, 95% are benign. So a thyroid nodule can form for any number of reasons, but almost all of this is benign tissue, and it's extremely common.
Well, that's good. I'm glad you're saying that, because I think if anybody feels a lump, what's the first thing we go to? You go to Google and you go to the worst. You're thinking the worst, so you want to get it checked out. But it has to make you happy that Sandy was doing her research and already knew about RFA, knew to ask about it. So until recently, the standard treatment was to remove the thyroid, right?
Correct.
So, and you mentioned, I was going to bring Dr. Matterang just to kind of elaborate on it as well, just like the side effects after someone has that thyroid removed. And why was that the best option then?
Yeah, so traditionally surgery was offered before this technology was available to us. The downsides of having surgery are, you have to heal from a traditional surgery. There's an incision across your neck, so there's cosmetic issues. A lot of people will essentially, you're trading a lump for sometimes a big scar on your neck. So I don't know if that's the great trade-off if we're talking about a cosmetic issue with a lump. The other thing is, potentially with the surgery, there's some exquisite nerves that live in that area. So there's a potential to injure one of the nerves, a recurrent laryngeal nerve, something that controls your voice, the quality of your voice. If it's injured severely enough, even functions with your swallowing and things like that. And then the other thing that Dr. Reeves mentioned, one of the main things is if you take out some or most of your thyroid, you may run into hormone problems. Not having enough hormones, then you'd have to be on a medication for life to bring those hormones back to that normal level. And sometimes it can be difficult to replicate what was normally there when you remove the thyroid. So that's an issue that you won't run into with the thyroid ablation procedure.
And what if you just left it as is? You left the thyroid alone, you leave the lump alone?
Yeah, so these things are not cancerous, and we before we do this procedure, we prove that it's not cancerous with a biopsy. These things can fluctuate a little bit in size over time, get bigger, maybe a little bit smaller, but for the most part, it's a cosmetic thing for many people. But if it does get bigger, it can be more of what they call mass effect, which is pressing on your trachea or your windpipe or causing difficulties with swallowing. And so that's really more common. We've seen that people just say there's a fullness in my neck, there's discomfort. When I swallow, I can feel a sensation, things like that.
So it's got to go.
And so, yeah, and so this is a very, very common complaint for people that have these enlarged thyroid nodules.
So instead of surgery, we're talking about radio frequency ablation, or an actual radio frequency. Tell us about that and what it is.
Yeah, essentially it's just a fancy name for a specialized needle that can generate heat. This localized heat can essentially kill parts of the nodule. So you're looking with ultrasound at the needle inside of the thyroid gland.
And I think we have some animation
and
to
we'll show
this
you.
too.
Yeah, we'll show some of that later. Here's a little video, and we can go through this. So the procedure, in essence, is we use ultrasound to look at the thyroid. The thyroid on this video is just showing this little orange. And then once we have it localized, we insert this specialized needle. This is the probe, we call it, and we turn it on. There's many things that go on with this probe. But the main part is that it generates heat. We position the tip of the probe into multiple areas in the thyroid, and then once we feel like we've treated the thyroid, we're done. And then over time, it will shrink. So this is not something that we see result from overnight or even 2 weeks. Our first follow-up really isn't even until 6 months, because it takes several months for the thyroid to shrink over time.
So what type of patient is good for this procedure versus having the thyroid taken out altogether?
It's just an option. I mean, I think, once the advantage, I guess, of surgery is that once you take it out, the thyroid nodule is completely gone. In essence, what we're doing is we're shrinking the nodule, but it'll always be there, but we're shrinking it to a size where it's manageable, or where cosmetically it's not making a difference, or mass effect, it's not making a difference.
At a big scar, so it's less invasive. So
correct.
A lot of different types of benefits there.
Yeah, and just to answer your question a little bit further, every patient is a candidate as long as the nodule is not malignant.
Okay.
So in the United States, the FDA hasn't approved this device yet for use in malignancy. It will get there. It's used in Asia and Europe for this. And so we are in trials, or the United States is in trials to research this for malignancy. But outside of that, every patient that has a nodule is a potential candidate for this.
So they just need to ask and do their research the way that Sandy did. Sandy, you knew about RFA. When did you decide to come here to the health system and get it done?
Well, about a year after my initial diagnosis and original biopsy, I thought that the nodule was getting larger, and I had kind of decided that I would reassess in around a year. And so it was just about a year later that I decided to reassess the situation. I thought it had gotten larger. So I got online and started researching again. And at that point, magically, I was able to discover that the procedure is offered there at KU Medical Center, which made me very happy, because that's an hour from my home. And so in perusing the thyroid clinic website, there was a place to click through to request an appointment, and that's what I did. I gave some information about my case, the background, et cetera, and said I was interested in consulting with someone about whether I was a candidate for this procedure. And I got a lovely phone call less than a day later from someone there, I think, at the thyroid clinic. And then they set me up for an appointment, 2 appointments on the same day, which was wonderful for me since I drive over from Topeka, to have both an ultrasound and then a consultation with Dr. Buchek in the thyroid clinic there at the hospital. So I was able to do those, and she was able to see the ultrasound by the time we met to discuss. And during that consultation, it was determined that I was a candidate for the procedure. But of course, I was also requested to get a follow-up biopsy just to make doubly sure that there is no cancer concern. So that's how it started, before I then met Dr. Matarang in January.
So what was recovery like?
Oh, really very easy. I suspect people have had dental procedures and been in more pain. I was in I would call it mild discomfort. There was some, obviously, you've had needles cooking your thyroid, and so there's going to be some, in my case, some mild swelling just from having the procedure done. Some mild discomfort. I actually treated it with my neck with an ice bag, I think, for a couple of days. That helped a lot. I'm not even sure if I took an ibuprofen. I mean, I did not want any pain meds. I did not really need any. It was not that uncomfortable, and it faded very quickly. And within 2 weeks, I would not have known that I'd ever had anything done. And then over time, gradually, it kept reducing in size and reducing in size. And I would say my full result was probably visible even more, even earlier than 6 months. At any rate, certainly by 6 months, when I had my follow-up appointment, there you can see the difference. I had my follow-up ultrasound 6 months later, and the results were considered extremely good.
Yeah, Dr. Mettering, is this the result you expect to see from someone like Sandy?
Yeah, typically. So our first ultrasound check is at 6 months, and I reviewed her ultrasound. We got a 75% volume reduction at 6 months, which is right sort of where you want to be. I think even over time it may continue to decrease in size, hopefully get to 80%, maybe a little bit more. So, but we're shooting between 60 to 80% volume reduction of the nodule, and that typically is the number that gets you to where cosmetically it's a significant improvement, and also with the mass effect and pressure on your neck, those are the numbers we're shooting for.
And we have some ultrasound images from Sandy's case. Tell us what we're looking at here.
Okay, well, this is a ultrasound, just as focused ultrasound of Sandy's left thyroid lobe. So there's 2 lobes to the thyroid, one on the left, on the right. But this is her left lobe, and essentially that big round thing in the middle is her thyroid nodule. It's essentially replaced the left side of the thyroid gland. So really what we're just seeing is this round thing. It's hard to see the measurements, but it's an almost 5-centimeter nodule on that left side. So that's a very common appearance for a thyroid nodule. And the same technique to biopsy, we'd use an ultrasound. We would slide a small needle in there to take the biopsy. After the treatment is that second image there, and you can see just to the quality of your eye, the one looks bigger than the other, the before and after. And so we're just measuring that, and that decreased by, I can't remember, down to 3 centimeters or so, but based on our volume calculators, it was 75% decrease. So that was our first checkpoint. So again, I think it's going to continue to decrease in size here over the next year.
Yeah, those before and after said it all. What else is RFA used to treat in the body?
Yeah, so this technology is new to the thyroid, but it's been used in other places in the body, at least closer to home. What we use RFA in the spine, so spinal tumors we've used RFA on. Really any part, any bone in the body you could potentially use RFA technology on.
How new is it?
RFA has been around for a long time, probably 20 years, maybe more. It's just the approval to use it in the thyroid has just been recent.
It's evolved to be able to treat other
Exactly.
areas.
And really just designing probes to get to the size of what you need to treat. But yeah, solid organs, liver, kidneys, there's many applications for ablation technology, and it's not always just heat. It can be freezing it, or it can be heat. So it's called thermal ablation. That's sort of the broad category that we use these tools to either freeze something to kill it, or apply lots of heat to kill it.
Okay. That makes sense. Mm-hmm. I understand all that. You broke it down perfectly. So we had mentioned at the top of the show that there's only about 75 doctors in the country that perform this. So why you two? This is where you have to brag and say, I figured it's not available everywhere, but you guys are also pretty darn good at your jobs.
Well, I think it's a twofold answer. One, the technology has only recently become available to be able to target the thyroid gland for this procedure. So, like Dr. Mettering said, the technique has been around for a long time, but the technology has only been in the last few years to be able to use a probe to get into a very small area of the thyroid gland. That's one. The other one is that it takes a lot of technical expertise to pull this off. It looks simple on a video and it looks simple when he explains it, but the reality is you have to be able to use both hands at the same time, one working the ultrasound, one working the probe, be able to monitor the output on the probe. There's a lot that's going on. And as interventional radiologists, we're perfectly suited to do this because we do a lot of these types of procedures all over the whole body. Mm-hmm. And then the other reason is there's not a lot of people that focus exclusively on the thyroid in their practice. We don't focus exclusively on that, but we have a lot to do with the thyroid gland. So a biopsy uses a very similar type of technique for what we need to apply to do an RFA. So we've had a lot of combined experience doing this, more than probably anyone else in this whole city, doing thyroid procedures. Since that number came out, there's been more than 75 people that are doing this procedure, but it's a kind of a multifactorial component as to why this is not really super penetrated yet in the number of doctors that are doing this.
Well, yeah, and you're just very specialized in that. So is it fair to say this is becoming or will soon become the standard treatment for thyroid nodules?
I think that it will be one of those treatments that will be, like in Sandy's case, a very, very strong option for people that didn't have this option before. Her story is so representative of many patients that we see here, where they have been given an option, which is do nothing or do surgery. And those options don't seem very good in today's modern world. They do research, they find out that this technique is available, and they end up here or somewhere else where it's being offered. So I think that this is one of those examples where we are on the beginning of a wave of patients that will be experiencing what she's experienced.
Sandy, you shared some photos from the weeks and months after you had your procedure. You went on a fantastic European tour. Did your neck bother you at all? Tell us what that was all like.
No, I left for Europe a few weeks after the procedure and never gave it another thought. I mean, it's just normal life. That's the best way I can put it.
What were the highlights from your trip?
Oh, I managed to hit Sicily in March of last year before I realized it's like the big thing in travel right now because of some television show that's set in Sicily. Now, apparently everybody wants to go there, but I got there first, and while it was very uncrowded. So that was great.
Nice. And you had mentioned before the program started that you were, you're back to wearing the clothes that you love to wear and being able to show your neck, right?
Yep. And tank top season is on the way,
Yep. That's right. Yeah. Sun's out, guns out. You're going to want to show it all off, and I get you. Yep. So, yeah, I get you. You're looking great. So be sure to ask your questions. Use the chat on YouTube or Facebook. We're on the X platform. You can email the Medical News Network. You can check out the information there on your screen. And while you send your questions into us, we're going to check the COVID count for this week. There are 8 active inpatient at the health system as of Monday. That includes 2 patients in the ICU. One of them is on a ventilator. And we're going to hear more from Dr. Hawkinson tomorrow when we have a special guest host filling in on Open Mics with Dr. Stites. Well, let's get to some of those questions from our viewers. So if your thyroid is removed, do you need to be on meds for the rest of your life?
Yeah, so yes. So if it just kind of depends. If they take out your entire thyroid, which is called a total thyroidectomy, then you'll have no more hormones. So it would need to be hormone replacement for life. When we're talking about a nodule that's removed, we're talking about a partial thyroidectomy. Not everybody goes on the replacement, but I think about 20% of patients that have at least partial thyroid will have to need some hormone replacement to sort of top them off. So. Yeah, to answer your question, if it's a smaller part or partial thyroidectomy, not all patients need thyroid replacement, but about 20% will end up needing it.
Mary Jane wants to know, would this procedure be a good treatment for someone with Graves' disease?
That's a great question, and the short answer to that is it's possible. So there's a small set of nodules called hyperfunctioning nodules, and those can lead to excess hormones or changes in your hormone levels that are hard to regulate. Graves' disease has a lot that goes on with it in terms of your eyes as well. So I think that particular question will be answered in the coming years as to whether this is a good option for people with Graves' disease. I think it's difficult to determine that, and it'd have to be on an individual basis to check their hormone levels, do certain types of scans to see if the nodule is hyperfunctioning. And we have done that in our practice before. To make a blanket statement that it's good for all Graves' patients would be difficult, but I think it could be evaluated on an individual basis.
Ruth Ellen wants to know, was there ever a procedure on the thyroid to drain a gland?
I think what you're probably referring to is, along with thyroid nodules. So nodules come in basically 2 flavors: a solid nodule, which is firm tissue, and then another in that family is a cystic nodule, which is mostly fluid. So it's not uncommon that these nodules can be either cystic, more fluid-like, or more solid, but most of them are a little combination of the both. But yeah, if it's primarily a cystic nodule or fluid filled, yes, it can be drained to relieve the pressure. The downside of that is that sometimes this fluid can reaccumulate, sometimes very quickly, even over the course of one day it can fill back up. So sometimes there are other procedures that we can do. It's not RFA specifically, it can be, but injecting medication inside of the cyst to get the shrink, to get the cyst, the wall of the cyst to shrink, treat it that way. So there are other techniques we can use for draining fluid.
Dr. Reeves, you had mentioned earlier about this not being FDA approved for malignant lumps. Jeremy wants to know why it's approved for somebody like Sandy, but not for malignant lumps at this point.
Yeah, that's just the FDA doing its kind of slow roll.
Yeah.
That's all it is, and it will happen. Like I said, it's already being used in Asia and Europe for this, and there are trials underway. So I am confident that the FDA will eventually get there, and it probably won't be too long, within the next year or two.
A good old FDA approval.
Yep.
It's quite like you said, the slow roll. So is this covered by insurance?
That's a great question too. We get that question a lot. The answer is a yes, it is. And I believe that when this was started early on, patients did have some difficulty with getting it covered. Locally here, our team has done a fantastic job of getting pre-approval authorization, so we don't usually have that problem. And it tends to be regional. However, there are new CPT codes just for this procedure. Once those came out, that validated the procedure as a legitimate procedure, and then insurance companies will be able to look at those codes and be able to say, okay, this is a legitimate procedure, we're going to reimburse for it.
Last question. Will Sandy ever have to have this procedure done again?
It's unlikely. Even though the nodule is still there, once you treat it, the durability is proven over time that most people don't need to have it done. You know, sometimes when you're dealing with much larger nodules than Sandy's, sometimes you might want to do a retreatment if you didn't get the result that you wanted. But yeah, we have not yet retreated anybody for it growing. We've been doing it for 3 years, and that supports what the literature says, that typically you don't need to retreat. If we do, if it starts to grow, we could bring her back in, but I don't anticipate that.
Don't see that happening.
Yeah.
Dr. Mattering, what's the takeaway today from this conversation?
Just that I think there are new options for people with thyroid nodules that are, you know, if it's a cosmetic concern or if it's a discomfort or mass effect in your neck. I think the traditional way was surgery, but now I think as technologies evolve, there are other options, less invasive, have it done same day, go home, and not have to deal with the traditional things with surgery, with scarring, infection, trying to recover from infections, and, you know, potentially hormone replacement therapies we can avoid.
Dr. Reeves, what's the takeaway?
Well, I can't say it any better than he did. Mine would be we're quick and clean and ready to help.
I like that. And do your research, right?
Yeah.
Do your research and ask questions. Sandy, do you have any trips planned, by the way? Where are you heading to next?
Oh, yeah. In 2 weeks, I'm heading to Seoul, Korea for just a few days, but then I'm hopping from there over to the Philippines, and I'm going scuba diving for about a week and a half.
That's what we call living our best life. I like hearing that. I like it that you're out there and about there. So, Sandy, just tell us what you want people to take away from your story.
My strongest advice to everybody out there, and I know a lot of the folks afflicted with thyroid nodules, they tend to be, I think, mostly women, I think, statistically, and the doctors can correct me if that's wrong, but don't just take no for an answer when you go see someone and they tell you your only option is to have it removed or to live with it. That's not true. And ask questions and advocate for yourself and self-refer if that's what you need to do. I was treated so well by everyone there at KU Med, and I recommend them without reservation. And if I had to do it again, I would.
I'm going to sneak in one quick viewer question. Sue wants to know, does this work for hyperparathyroid disease?
So yeah, it's not been studied specifically for that. So to answer your question, no, we're not treating parathyroid conditions. The parathyroid gland sits typically behind the thyroid. There's different clinical manifestations of that, and that's traditionally a surgical disease if you want to remove that.
Docs, thanks for being here with us today. We appreciate it.
Thank you.
Sandy, thanks so much for sharing your story. It was such a pleasure having you on today.
Thank you, and you're welcome. glad to help out.
Great. And thanks to all of our viewers, as always, for being with us and asking your great questions. We'll see you back here tomorrow at 8.
The freedom that can come from not being, bound to the fear of having a migraine is very exciting.
Freedom from migraines without a pill, spray, or drug. I'm Jessica Lovell on the next Open Mics with Dr. Stites. Migraine relief surgery offered close to home. Why patients are desperate for a permanent fix, and how to tell if you're a candidate. Wednesday at 8.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.